So what are the structures normally visualized using ultrasound that you mentioned? The airway structures of importance, the anesthesiologists are the tongue, epiglottis, hyoid bone, larynx, vocal cords, cricothyroid membrane, etc. And what are the different approaches? What you mentioned, there are two approaches. One is transcutaneous, where you examine the upper airway from the floor of the mouth to the suprasternal notch. And the various orientations you can use are the sagittal, parasagittal, transverse, and oblique planes. And for the transoral and sublingual approach, you have these probes which are in close contact, but it is little irritable to the patient and not useful for children. And clinical applications, first thing is we can use it for prediction of difficult airway. The second thing is we can identify the cricothyroid membrane, especially in patients who are obese or who have some other anatomical distortion. It can be used to identify the cricothyroid membrane, especially for the front of neck access when you want to do a percutaneous tracheostomy or cricothyroidectomy. And you can use it for appropriate endotracheal tube size, determination of the W1 tube, all to mention, confirmation of endotracheal intubation, confirmation of correct ET tube depth, and especially in pediatric patients because you can push the tube to one side. And tracheal rapid ultrasound saline test, which is also used to inflate the cuff with the saline to find out that will give a better penetration of the echo waves and give you a visualization than an air-filled ET cuff. And this helps to assess the confirmation. So this may be asked in your Viva, what is thrust using ultrasound. Then you can remember this point that you have to fill the cup with saline instead of air to assess the correct depth of ET tube placement. Then detection of endobronchial tube intubation, which also she mentioned, and facilitation of percutational dilatational tracheostomy, and it will prevent all false passages or injury to vessels. All that can be easily done using that. And prediction of post-extubation stridor, detection of laryngeal mask airway position, that is also very useful. Assessment of vocal cords and determination of lateral laryngeal injury after especially thyroid surgeries, you can use this. And for especially patients who are uncooperative for a laryngoscopy or a FOB to assess the recurrent laryngeal nerve, right, you can use ultrasound. And detection of tracheal stenosis, determination of tracheal wall thickening, and tracheal invasion due to thyroid cancer, identification of intrathoracic extension of goiter, diagnosing epiglottitis, diagnosis of OSA by submental ultrasound. You measure these parameters and try to find out how severe it is, and ultrasound guided upper airway anesthesia to facilitate awake intubation. Limitations of ultrasound are is operator dependent and the image acquisition dependent on equipment and the operator. Interpretation again is operation dependent and it takes time to learn the technique, master the technique. So these are all the points that you have to remember. I have also taken these points from the same article and it is available in the net. All of you can go through and read that. Will you finish up the last topic also?